Good afternoon. Welcome back to Grand Rounds. Please remember to sign the attendance record at the back of the auditorium, and also please fill out the program evaluations and turn those back in if you could. And if you'd have any ideas in regards to future topics or future speakers, as always, we would appreciate those. Today, I am particularly pleased to have the opportunity to introduce Dr. Issa. Dr. Issa is a Senior Associate Consultant in the Division of Hypertension and Nephrology at the Mayo Clinic. He did his nephrology fellowship at the Cleveland Clinic, and then did his nephrology transplantation fellowship at the Mayo Clinic, where he is today. And he has been the recipient of multiple awards. He's been extensively published. He's been a peer reviewer for several journals in the realm of nephrology, and he kindly has accepted our invitation today to come and update us on kidney transplantation for the primary care physician. And please join me in welcoming Dr. Issa.
Okay. Thank you so much. This one? Hello? Can you hear me? Oh, this one? Okay. I know I have many of those. Thank you so much for the kind invitation to present into Grand Rounds. You know, I think it's an extremely important topic to educate primary care physician and whoever is involved in the care of patients. You know, now the success rates for kidney transplantation are very high, and I'm sure many of you have been involved in the care of kidney transplant. You come along the medications, and so it's good to be familiar with the common medical problems that they have. So we'll proceed. Sorry. I have nothing to disclose. So I'll go over the objectives that we will cover today. Initially, I'll review the basics of kidney transplantation. I want also to really stress that kidney transplantation is the best modality of renal replacement therapy. It's not cure for kidney disease. It's actually a form of therapy. Now, the patient still has to take medication lifelong. Sorry. And they have to come for appointments and see their physicians. We review the basics of transplant immunosuppression. I think it's very important. And we'll touch on the long-term medical management of some medical issues that come along with kidney transplantation. And I'll give you just a brief summary at the end for the reasons when you have to refer the patient back to the transplant center. I'll start with a case. I think it's nice to start with a case. We have a case of 54-year-old gentleman who received deceased donor kidney transplant for end-stage renal disease attributed to hypertension. That's an old transplant patient from 1998. Has good post-transplant course, never had any rejections. He's on those medications, cyclosporin, Imuran, and prednisone. There's creatinine of 1.9. He goes to the ER on a Sunday night for tenderness, swelling, and redness over his left big toe. CBC was unremarkable. Creatinine at baseline, has very high uric acid, and the suspicion for a gouty attack. At the ER, they give him a dose of colchicine, and they give him allopurinol, and sent him home and told him to follow up within a week with his primary care physician. He follows with his primary care physician as predicted, and he did some labs that day. His white count is very low, 0.8, has thrombocytopenia, he's very anemic. Serum creatinine remains at baseline. And the question, you can mark your answers, and we'll go back to those questions at the end. What caused the patient to have the severe pancytopenia? Is it the colchicine, allopurinol? Is it a new blood disorder that needs to be worked up? Or interaction between the Imuran and allopurinol? We'll get back to that at the end, so you can think about it. Another case, 22-year-old young lady had advanced chronic kidney disease stage 5 due to congenital uropathy. She has also recurrent UTIs as a child. She's in kidney failure, creatinine 4.5, estimated GFR of 13. Primary nephrologist giving her the options for renal replacement therapy, hemodialysis, PD, peritoneal dialysis, or transplantation. She has potential donors, a brother and her mom. And question is, what's the best renal replacement modality that you counsel the patient to get? Is it waiting for a deceased donor kidney transplant? Go ahead with dialysis, whether PD or hemo, or preemptive living donor transplant, meaning before she goes into dialysis, or living donor transplant after a course of hemodialysis. And we'll get back to that. Sorry. So we'll go over kidney transplantation. As I said, it's the most effective treatment modality for end-stage renal disease, not because it relieves the patient from constraints of dialysis. It's mainly because it increased the survival of patients after successful kidney transplantation. Obviously, not everyone benefit from transplantation. This is why they have to go to the transplant center and have a thorough evaluation. And it comes after they are approved to find a donor, whether from a deceased donor or a living donor. And also we subject the living donor to very exhaustive workup to determine their suitability to donate. Why primary care physicians and internist role is very essential. As I said, we have more and more success with kidney transplantation. We see now a lot of patients who had their kidney transplant many years ago. They're out in the community. They see their primary care physician. And they're exposed to chronic immunosuppression and has a lot of repercussions and comes with a package of complications and issues. So I think primary care physicians needs to be involved, needs to have some grasp on how to deal with those patients. And most importantly, the role of primary care physician is screening, education of those patients, for example, cardiovascular disease prevention, skin cancer screening in this population. The first successful kidney transplant that we know of was in 1954 between two identical twins in Boston. But I think the turning point in transplantation was in 1980s when cyclosporin was discovered, where the transplant outcomes really improved. And nowadays, we have more and more medications that are on the market, and we'll go over those in a minute. And most importantly, we have more antimicrobial therapy, so all the infections that those patients were dealing with now are taken care of by new antivirals, antifungals, and antibiotics. I think this is a very important slide. And this is why we offer kidney transplantation. If you look here at this graph, that's the projected life expectancy from the time of end-stage renal disease. I take an example. If you have a 40-year-old patient and you're counseling them about what to do when they have end-stage renal disease on the verge of starting dialysis, if they get kidney transplant, as you can appreciate here in yellow, they have actually normal life expectancy, similar to the average population. With a deceased donor, whether from an extended criteria donor or non-extended criteria donor in blue and orange, still they benefit, their lifespan is increased, and their lifespan with dialysis is very dismal. And that applies to all age groups, even people who are older. I just saw a patient actually on Monday, 76-year-old, and they asked me the question whether he benefits from kidney transplantation. He's on the verge of starting dialysis. Typically, on those patients, we recommend a living donor because the waiting time for transplant is long, so they still benefit from kidney transplant. And perhaps the best and the most important advantage that kidney transplantation does to patients with chronic kidney disease is halting the progression of cardiovascular disease. You can appreciate here, after kidney transplantation, orange, we see initially, we see a little bit of cardiac events around the kidney transplant, surgery. Most of those patients come with a burden of cardiovascular disease and diabetes and hypertension and chronic kidney disease for years. So there is actually perhaps a little bit increased risk initially after the surgery, but thereafter they benefit from less cardiovascular disease and less cardiovascular death. If they remain on the waiting list, as shown here in blue over years, their mortality is high. And that's actually, we observe that on daily basis. We list patients for kidney transplantation, they don't have a living donor, and they wait a long time, and we see death on the waiting list. That's another more registry analysis, more recent from the USRDS, showing the benefit of kidney transplantation compared to remaining on dialysis. And as you can see, across all age group in blue, kidney transplantation confers longer life expectancy compared to dialysis. You know, that's very well shown in many, many studies. And unfortunately, patients on dialysis have actually higher risk of dying than common cancers. If you look at mortality in 5 years in dialysis patients, about 60%. The average lifespan on dialysis in the US is about 7 years. Now, all age group taking every patient coming in, including diabetics. So kidney dialysis or being on dialysis is not the best option. Now, there are other multitude of quality of life benefits. The maintenance of employment, it's very important. Unrestricted diet. In childbearing age for women, they can become pregnant and bear children after transplantation. We cannot maintain pregnancy during dialysis. They can engage in sports. And of course, the lifestyle free of dialysis constraints, whether for the patient or the family and the caregivers. So when is the best time to refer a chronic kidney disease patient? It's actually ASN, American Society of Nephrology, American Society of Transplantation recommendation, and KDIGO recommendation to refer a patient when they hit the GFR of 30 and below. Now, we can't list them active on the waiting list to accrue waiting time unless they hit a GFR of 20. But we prefer actually to do a preemptive transplantation. As you can appreciate here, if the transplant is done preemptively without doing dialysis, we have the best patient survival and graft survival. So I tell patients who come for new evaluation, you know, when you start dialysis, the clock is ticking. You know, it's important. The best outcome is to do the transplant when you're still not sick and before starting dialysis. And that has been shown in many studies, including this one. Now, what are the contraindications for transplantation? Not everyone benefit, and not everyone is a suitable candidate. If someone has an active malignancy, we typically advise on waiting, depending on the cancer. If it's metastatic cancer, it's an absolute contraindication. Decompensated cirrhosis, unless they're listed for liver transplant. Irreversible coronary artery disease, it cannot be revascularized. Active mental illness, if the patient does not identify a caregiver, unable to grant informed consent and follow with taking their medications and adhere to them. Active substance use, typically we subject to those patients to chemical dependency consult, and we follow on them. If they don't prove that they're clean, we deny them access to transplantation. Chronic infection, extreme obesity, and we're talking here about BMIs, you know, that are really, really high, 45, 50 and above, unless there is a bariatric surgery that's planned. What about the advantage of a living donor transplant? As I said, there is a preemptive transplant option. It's an elective surgery. You can do it, time it whenever you want. No wait time. You know, average in our area in Minnesota, average waiting time for a deceased donor is 5 years. It can go up to 10 years in certain areas, metro areas in California. It's about 9 years in Chicago area. So it's really, really high, the waiting time. And there are other benefits, better outcomes, and there are some benefits to the donor as well, the emotional gain and others. How we evaluate donor-recipient compatibility, they have to be blood compatible. And we also do HLA matching. If there is any problem with incompatibility, we put those patients or the pairs in paired exchange program, and we've been successful in doing that. As I said, the wait list for deceased donor is, for a deceased donor organ is very long, especially for those with blood type O and B. And as I said, we list patients actively, so they start accruing waiting time of their GFR is 20, that magical number and below. And patients can be advised that they can list in several transplant centers if they have the means to do it. If you look at those patients who were listed in 2010, only 63%, only 1 out of 5 of those patients listed in 2010 received the kidney transplant within 3 years. And only 63%, and 63% did not receive a kidney transplant within 3 years. So that's actually really a long time. And some of our patients, if you deal with them on dialysis, you know how sick they are, and they have the burdens of cardiac disease and other diabetes and other comorbid factors. We'll go over the transplant immunosuppression. I think it's good to have some idea about the medication. You probably hear about them, and you hear the names. They get sometimes confusing because some of them have several names. And in an ideal world, the goals of transplant medication is to confer 100% long-term patient survival, graft survival as well, no acute rejection, no side effects, and excellent kidney function. Unfortunately, we're not there yet because those medications that we use have a lot of side effects that I will go over in a minute. Now, as I said initially, until mid-1980s, when cyclosporin came into transplantation, we had really bad outcomes. If you see in yellow, the rejection rates in the 60s and 70s were about 50 to 80%. Thereafter, after the introduction and the advent of new medications, rejection almost unheard of these days, actually. Within the first year, I would say less than 10%, 5% acute rejection. The only risk factor for acute rejection nowadays is non-adherence to the medication. And as you can see, there are many new medications that came after cyclosporin. The main one was tacrolimus or Prograf, and Cellcept or mycophenolate mofetil, and we still have some medications. So what are the common combination of immunosuppressive medications? We have a primary agent, usually a calcineurin inhibitor, whether cyclosporin or tacrolimus, mostly tacrolimus these days. And second agent, usually Cellcept or mycophenolate mofetil, plus minus prednisone. The reason I'm saying plus minus prednisone, because steroid avoidance now is gaining grounds, and we actually have a lot of patients who are on 2 medications. We are successful actually in withdrawing prednisone within the first few days. Because you know, prednisone has a lot of side effects. What are the common side effects of calcineurin inhibitor like Prograf and cyclosporin? Hypertension, glucose intolerance, new onset diabetes for tacrolimus, tremor, and neurotoxicity for tacrolimus. There are actually also nephrotoxic drugs, especially at higher levels. This is why initially in the first year we check levels of tacrolimus and cyclosporin, and we're very vigilant about keeping it within therapeutic range, because if they get exposed to those medications for a long period of time at high levels, they can have chronic kidney disease and lose their graft. Other side effects, alopecia is very common for women with the use of tacrolimus, and hirsutism with cyclosporin, something that we see. That's actually a side effect profile for the common medications. Cellcept or mycophenolate mofetil or mycophenolic acid has a lot of GI side effects, especially diarrhea. It actually can be incapacitating, so a lot of times you have to switch different medications. Tacrolimus mostly new onset diabetes and glucose intolerance. And that's actually very important for primary care setting, is the medications and potential interaction with meds. If you're caring for a kidney transplant recipient or a solid organ transplant recipient on Prograf or cyclosporin, before you administer any new medication, it's very important to check if there is interaction, because a lot of common things that we order actually are can interact with those medications, contraindicated to be used. A very common stuff, some of the calcium channel blockers, diltiazem, nicardipine, amlodipine, they increase calcineurin inhibitors. Amlodipine not as much, but diltiazem can actually increase, cardizem can increase the CNI level. At times also we see people who take some herbal preparations, like St. John wort, it actually decreased the CNI level, and we've seen rejections happening with those patients who take some herbal stuff. You know, the good news these days, we have electronic health records where we actually enter the medication and we get this highlight, or there is interaction with Prograf or cyclosporin. In the past, it was hard when we wrote prescriptions, on paper. And second degree of safety net is, our pharmacists. A lot of time they call us and say, oh, there is interaction with tacrolimus. Do you still want to use this medication or so? But sometimes, some patients fall through the cracks. And recently I had a patient, similar to the first case, who got prescribed allopurinol, and he was on Imuran, and came with aplastic anemia and infections and died later on in the ICU from septic shock. So it can be a major problem. Now we'll switch gears to the common medical issues that you encounter in the clinic in dealing and taking care of transplant recipients. Hypertension is prevalent. A lot of patients, when they come to the clinic, being evaluated before transplant, they ask me, I'm on 6 blood pressure medication, will I come off those meds? The common thing, yes, we may trim down some of the medication, but a lot of those patients remain on some blood pressure medications. Mainly because, first of all, we have older population, they had hypertension, essential hypertension for a long time. And also the medication we use, the calcineurin inhibitors like tacrolimus and cyclosporin, they cause also hypertension. The target goals, we follow the JNC8, National Kidney Foundation guidelines, keep the blood pressure less than 140 over 90. Preferred therapy, because you saw some antihypertensive can interact with the meds, their own. First line therapy, I choose amlodipine. You see a lot of our patients amlodipine. The reason is the interaction is not as severe with cyclosporin or tacrolimus like the others. And beta blockers, second therapy. Now the ACE inhibitors and the ARBs, angiotensin receptor blockers, we typically avoid them in the first year. The reason is they may increase the creatinine, so we don't know whether this is rejection or caused by the medication. Also, for some reason, we don't know why, they cause anemia in transplant patients, interaction with the meds. Typically, at 1 year after transplant, we feel more liberal about using ACE inhibitors and ARBs. As common causes of post-transplant hypertension, pre-existing hypertension, higher BMI, and the immunosuppression, I would say this is the most common causes. New onset diabetes is extremely, extremely an issue. It occurs actually in up to 25% after transplantation. And the reason is, when you're on dialysis or have chronic kidney disease, whatever the pancreas is secreting in terms of insulin is enough, because some of the insulin is metabolized by the kidneys. And those patients don't have any kidney function or very reduced kidney function. So we establish good kidney function after transplantation. The 20-25% is now metabolized of insulin metabolized in the kidney. So their insulin, they have become more insulin, first of all, resistant because of the use of meds, especially tacrolimus. And also their insulin secretion is not, through the pancreas is not enough. Plus, tacrolimus has been shown to be also toxic to islet cells in the pancreas. So it's a major problem that we see. And we counsel patients when they come pre-transplantation about that, especially middle-aged patients. We tell them, especially patients who are overweight, we tell them, you may become diabetic after transplant. There are some modifiable causes, being overweight, the use of tacrolimus, the use of steroids. Now we shy away from steroids in certain patients. Actually, when I see a patient who's overweight and planning on transplantation, we try our best to avoid long-term use of prednisone. Other issues, hepatitis C is associated, and now we have treatment for it. CMV infection post-transplantation has been shown as well to cause the new onset diabetes. There are things that we cannot control, being some ethnic background, being African American or Hispanic, because there's more prevalence of diabetes. And older people, I would say middle-aged patients are at more higher risk of becoming diabetic post-transplant. What about hyperlipidemia? It's frequent, especially with the use of cyclosporin, the use of sirolimus, which is another medication. It's called an mTOR inhibitor. Sometimes we have to actually make changes in the immunosuppressive medication in those patients. I have some patients had an LDL of 400 or 500 on sirolimus. So they have to come back to the transplant center. We make modification of their immunosuppressive drugs. And the targets that we target, similar to the population, an LDL less than 100, or if they had cardiac disease, we tend to also target the lower LDL. As I said, major factors using use of sirolimus and the usual typical risk factors for hyperlipidemia. Now, the problem is the use of statins post-transplant, because most of the statins are interact in the liver with tacrolimus or cyclosporin. So the tacrolimus or cyclosporin increase the statin level by 2 to 3 folds. So if you put someone on atorvastatin or Lipitor 10, and they're on tacrolimus, this is as if they're taking actually 20 or 40 of atorvastatin. So you have to be careful. So we usually start with very low dose and increase it slowly. Recently, the FDA issued a warning regarding the use of more than 20 milligram of simvastatin or Zocor in transplant patients. There were a lot of issues with the rhabdomyolysis in those population. So typically, we start with very low dose, 5 sometimes, of Lipitor, and we increase it slowly. Sometimes we use other medication if the statin itself does not, we cannot increase the dose and does not reduce the LDL, we can add Zetia at times with mixed success. Post-transplant anemia is very common as well. It's mainly common in the first few months, I would say. Thereafter, it's less. But I see patients, 2 years post-transplant, they come to the clinic with a creatinine of 0.8, very successful kidney transplant with a hemoglobin of 9. They're anemic. And there are multiple factors why they're anemic. And they can be many of those, interaction of those. I would say iron deficiency is very prevalent in those patients. they carry that burden of being iron deficient since they were on dialysis. Um, if the kidney is not working well after transplant, marginal kidney function, the kidney itself does not secrete much erythropoiesis, stimulating agents, EPOGEN, so they become anemic. Certain infections, if someone is very severely anemic, which we check for parvovirus 19 and CMV. Previous history of acute rejection is associated as well with more anemia post-transplantation. And the drugs themselves, I would say the big one is Imuran or azathioprine, is actually is myelosuppressive. And the use of ACE inhibitors and angiotensin receptor blocker in transplant patients, we don't know. There are a lot of speculation why it causes anemia, but we see it actually almost on daily basis. When we start someone on low-dose ACE inhibitor, they come actually within a month or two. Their hemoglobin was 14, they come with hemoglobin of 9 or 10, and they become anemic. So that's to keep in mind dealing with kidney transplant recipients. Post-transplant bone disease, also an issue. Actually, in the first few months post-transplantation, a lot of patients lose some of their bone mineral density. It's an extremely important topic. We see a lot of fractures. Nowadays, we're on top of it. When we work up those patients, we have medication that deal with secondary hyperparathyroidism. But a lot of those patients come to transplant very deficient in vitamin D. The prevalence of vitamin D deficiency is very high in this population before and after transplant. And they have actually bone disease to begin with coming to transplant. Also, the use of steroids, actually tacrolimus as well, has been incriminated in causing osteoporosis and osteopenia. So we try to correct their hypophosphatemia post-transplant. If they have secondary hyperparathyroidism, sometimes we have to do parathyroidectomy. Typically, we wait a year. Post-transplant, the PTH remain high in the 500-600, despite using some of the calcimimetics that now are on the market, like Cinacalcet or Sensipar. We may offer them surgical parathyroidectomy. So our society, American Society of Transplantation guidelines, is to get a DEXA scan at the time of transplantation, and we do that at Mayo Clinic. Then we do the second one at 1 year when they come back for their annual visit, and then we do it annually. Sometimes we see a lot of resistance from the insurance company about getting DEXA scan, unfortunately, but it's actually a society recommendation because if we diagnose osteopenia or osteoporosis early, we can use biphosphonate and other medications. And typically, most of our patients, we still tell them, to take calcium, like any patients, and vitamin D, at least maybe 800 to 1,000 units per day, depending on their level of deficiency. And the steroid avoidance protocol now, we've seen less and less issues with osteopenia and osteoporosis post-transplantation. So that's a good, promising thing that we do. Gout, like the patient we saw in the first case, is also still an issue. A lot of patients tell me, I had a lot of gout before transplant, but when I got the transplant, I have more gouty attacks, and they ask me why. And sometimes it doesn't correlate with the uric acid level. We know that cyclosporin use is very, it's actually one of the main causes of being hyperuricemic or causing gout post-transplantation. So the medication we use causes gout. We have patients who never had gout before transplant. They start having gout after transplant with perfect kidney allograft function. And that's actually a board question for nephrology. They give you an example of a patient who had kidney transplant recipient who had sudden onset of pain in one joint, knee, or elbow, and they ask you what could be that, septic arthritis, and this, the answer is gout. And for some reason, we don't know why, gout post-transplantation involve more larger joints. So if you have a patient, kidney transplant patient, or heart transplant patient on cyclosporin or Prograf, and they come with monoarticular pain, if it doesn't look that bad or hot, we're not suspecting a septic arthritis, think about gout. Even with the uric acid that's not very high. Very common, I see someone with uric acid of 4 or 5, and they have a gouty attack, post-transplantation. It's not the rule in chronic kidney disease patients or patients who have gout. We try to avoid NSAIDs because, as you know, they cause kidney dysfunction, especially in allografts. So we try to use prednisone, high dose for a few days, or colchicine. And we try to avoid allopurinol in patients who are taking azathioprine because of severe myelosuppression. As I said, we recently had a case of someone who had aplastic anemia following administration of allopurinol, and he was on azathioprine. Now, I'll talk about infections post-transplantation. It varies over time. Initially, in the first few months, we deal with the common things like surgical wound infection, especially in obese patients. Patients sometimes go home with Foley catheter, urinary tract infections. Beyond the 4 months, we start seeing the opportunistic infections, CMV, some fungi like aspergillosis, PCP and such. Beyond the 6 months, I would say, because we lower immunosuppression, we start seeing more the community-acquired bacterial and viral infections. But still, whenever we have fever and transplantation, we're still about the bad stuff and the weird stuff, such as some fungi and other weird infections, yeast infections. Vaccinations post-transplantation is a major question that we encounter. Actually, I get calls a lot from outside physicians calling and saying, I have a patient, what do you think about giving them, such and such vaccination? We avoid all live vaccines. That's a rule. Actually, they're really contraindicated. With this flu season, we tell patients not to get the nasal spray flu vaccine. The IM flu, the intramuscular one is fine. The flu shot is okay. We deal sometimes with patients who have kids who get the nasal spray influenza vaccine, and the patient attracts the flu from their kids. So this is, if you're dealing with a transplant patient who have kids, tell them not to give them the nasal spray flu vaccine, because I've seen cases of very severe flu in the patient, and the parent was a recipient of an organ transplant because their kids get vaccinated with a nasal spray flu vaccine. Nowadays, shingles, especially in older population, we see a lot of transplant patients with shingles. Is contraindicated because it's a live virus. Now, the permitted vaccines, sorry, I was using this. Were you hearing me? Sorry, okay. The permitted vaccines, as I said, the flu shot, typically after 3 months of transplant, we can give it. We give it yearly as well. There is some issues related to the flu shot, increasing sensitization after transplantation, and we see sometimes rejection happening. But it's an actually CDC recommendation for all solid organ transplant patients, including kidney transplant patients, to receive the yearly flu vaccine, the injection. And Pneumovax and pneumococcal vaccines are fine to be given. Just briefly talking about other issues that we may encounter post-transplantation. I tell you, all cancers are at increased prevalence post-transplantation. This is why when we see those patients before transplant, we make sure they're updated on health maintenance exams. They've done their colonoscopy, we do a chest x-ray, and we do the common things. Because we see actually at least a twofold increase in common cancers such as lung, colon, pancreas, prostate, breast. Perhaps the most important cancer post-transplantation is skin cancer. I'll talk about that. It's the most common one. There is an entity called post-transplant lymphoproliferative disorder or lymphoma post-transplant, PTLD, you heard of it. It's typically associated with Epstein-Barr virus infection. The good news, if it's EBV-induced, we reduce immunosuppression, and there are some chemo agents that we give and can be curable. But some lymphomas can be aggressive as if they present in the central nervous system in the brain. It's very hard. We have to use some radiation, and so it can be a problem. The most important cancer, I said, is skin cancer, and they can be very aggressive, especially squamous cell cancers. Can be a problem. If you have patients 20, 30 years post-transplant, they have that accumulation of immunosuppression over decades. You see them suffer. They can have a more procedure every month. It can be an issue. So typically, we get a lot of consults of patients, who are 20 years or 30 years post-transplant. They have perfect kidney function. They're doing really well, but they have uncontrollable cancer. They have to see the dermatologist every month or every 2 months. So we make some alteration of immunosuppression with caution. And that's actually something that any primary care physician, if they encounter that, they have to refer the patient to the transplant center. A lot of time it's the dermatologist who initiate the referral back to the transplant center. They call us and say, can we reduce Prograf? Can we reduce CellCept? This patient has uncontrollable squamous cell. Now, we've seen patients who have metastatic squamous cell and die from it. So this is why the role of the primary care provider is very important about telling the patient to show up for their dermatology appointment, sending them on a yearly basis. And of course, the other recommendation of avoiding direct sun exposure and wearing sunscreen and such. Now, that's a busy diagram, but if you're dealing with someone, kidney transplant recipient, has great kidney function or stable kidney function, and they come with the rise of serum creatinine, if it's above 20% of their baseline, 20-25%, they need probably to be referred to the transplant center unless they're obviously dehydrated or not drinking fluids, because it can be a rejection. It can be a multitude of things. If you can see down in yellow, it can be a recurrent disease, and that can happen for patients with glomerulonephritis. Most of them recur early in the first couple of years. But we've seen recurrence of membranous nephropathy and others happening a few years after transplant, especially if there is proteinuria. There can be actually an issue with something called BK infection, BK virus. And that's an infection that's typical to kidney transplant recipients. It's a virus that's very endemic, and it's very ubiquitous among healthy people. 90% of the population worldwide has BK virus. It lives in the bladder, does not bother, does not cause any fever or anything. It can sneak to the blood, and we don't know why, in kidney transplant recipient and bone marrow transplant recipients. And from there, it can go through the blood to the kidney and cause interstitial inflammation in the kidney. And when the immune system tries to fight it, it mimics rejection, and a patient can lose their kidney transplant from BK infection. This is why any rise of serum creatinine many years post-transplant, if you're a primary care physician, pick up the phone, call your nephrologist at your hospital, or if you don't have access to nephrology, locally can call back the transplant center because we subject those patients to a lot of testing, including BK. Acute cellular rejection can happen all the time, and it's very rare, but the late ones can be detrimental for the kidney transplant, especially if you have younger patient. They can take their meds for 3-4 years, and then at some point, they start to be non-compliant, and then when we see actually acute rejection. And there are other things, that can happen, such as calcineurin inhibitor nephrotoxicity, acute interstitial nephritis, and others. So whenever you have a patient who start to have issues with their creatinine, that's actually a reason to refer back or refer to the local nephrologist in your hospital. So that's actually a slide about when to refer the patient back to the transplant center or consult over the phone with the transplant center. We always get those calls. At Mayo, we have doctor of the day that actually answers all the questions. I get questions from all over the world because all our patients are all over in the United States and everywhere. So they call us on daily basis asking questions. As I said, increased serum creatinine level, if we cannot explain it, by dehydration or new medication. New onset proteinuria, because it can be something that we can do something about it. It can be a cause such as, membranous nephropathy recurrence or de novo membranous. And now we have almost a cure in certain patients for membranous. If you have a question on reduction of immunosuppressive medications, don't hesitate on calling us. Late with steroid withdrawal. I see this a lot. A lot of patients come back many years and say, can I stop my prednisone? I have a relative who had kidney transplant at Mayo, and now you guys are not using prednisone. Can we stop the prednisone? I caution them about that. Late withdrawal of prednisone has been associated with significant risk of late acute rejection. Sometimes you cannot reverse. So we have patients on their own because they gain weight, have diabetes, they don't like it, they're irritable with prednisone. I don't blame them. They decide on stopping the prednisone. They're compliant with other meds. They come actually with a rejection. Sometimes you cannot control it. And we don't know why. Either this 5 milligram of prednisone can be that essential. Whenever you start a new medication, even over-the-counter medication, because of the interaction with immunosuppressive medication, so you can ask us about that. If they have recurrent infections, a lot of those patients tend to have recurrent UTIs. It could be a suture in the bladder that was left. We've seen patients coming from different centers where a stent, urethral stent, is left there, and no one knew about it. And they come with the recurrent urinary tract infection and septic shock and urosepsis. So it can be as easy as something that can be fixed, or it can be a complex problem, especially in diabetics like neurogenic bladder and such. Uncontrolled hypertension. If you're having a patient, you add medications, 3-4 medications, their blood pressure are not well controlled. We can be dealing with renal artery stenosis of the kidney transplant. It can be actually the native kidneys can be pressor kidneys, especially in polycystic patients. So it's important, if you have this problem, to consult with nephrology or the transplant center. Mentioned the recurrent uncontrolled skin cancers and what vaccinations are safe. And any questions, we welcome that. So to go back to our cases, for the sake of time, we'll be quick. So what caused the patient to have the severe pancytopenia? It's actually the interaction between Imuran and allopurinol. Because when you take Imuran, it's actually metabolized to 6-mercaptopurine in the liver. And then allopurinol, when you take it, it inactivates an enzyme called xanthine oxidase. And when we start allopurinol in someone who's taking Imuran, that 6-mercaptopurine is uninhibited and build up in the system and can cause very severe myelosuppression, can cause actually myelosuppression and can cause aplastic anemia. So this is why it's important for primary care physicians or providers whenever they prescribe new medication is to check that to avoid any life-threatening drug interaction. And you may think this doesn't happen. It happened recently, and it is sad to see it happen. We have a lot of safety nets when we order medications. The problem I've seen, not the primary care physicians, actually mostly the ER. They go to the ER, because they don't, when they prescribe medications, they don't actually check their list of meds, or that system does not tell them or alert them that there is a problem with use of this medication. We see this mostly in ER settings. We've seen, patient going for a gouty attack to the ER, and they put them on large dose of indomethacin, and they come with kidney failure. So this mostly in urgent setting where this can happen. Now, to go back to the second case, that young lady, 25-year-old, on the verge of starting dialysis, and how we counsel that patient. Hopefully you appreciated that doing a preemptive living donor kidney transplant is the best option for that patient before dialysis, because there is a lot of data showing us that when dialysis starts, patients do not do well, even younger ones. At Mayo Clinic, we have 3 locations. We are actually considered one transplant center. We're the largest living donor transplant program in the country in Rochester. The 3 sites in Jacksonville and Scottsdale, we actually do around 700 to 750 transplants a year. So we're actually the 3 centers in one center are the largest transplant center in the country and in the world. We have options for patients who come to Rochester, who travel, to stay at the Gift of Life Transplant House. They love it. Actually, we have 2 transplants. That's the old one. We have a new one as well. They can stay for a nominal fee. So if they come to Rochester to have their transplant, they have the options of staying for long or prolonged period of time at the transplant house. I'd like to thank you for attending the presentation and for inviting me to come here. Thank you so much. Can open it to questions.
Thanks for the talk.
Sure.
I'm one of the internists here. A couple of questions. So what of the different immunosuppressants you use, what are the ones which we need to follow the levels on? I know sometimes we get like annually, every 6 months, like
Right.
cyclosporine or tacrolimus, or we don't. Some of them we don't need to follow levels. The second question is, all the dialysis patients that pretty much they go on Medicare once they get on dialysis. So let's say they get a transplant. Will there be any changes in the insurance dynamics there? Will they have to go back to work or something?
Yes, those are very good questions. Typically now we have 3 medications that we use: tacrolimus, Cellcept or mycophenolate mofetil, plus minus prednisone. So the one that really have the very therapeutic, narrow therapeutic range is tacrolimus. So in the first few days, we do it almost daily in order to build up. And we have a protocol, actually. The first 3 months, we do it initially for a month. We do it weekly after they leave the transplant center. Then they do it every 2 weeks. When they reach the 3 months mark, if they're doing well, we do monthly prograph levels. And at the 1 year, if they're fine, then we do it every 3 months. Because over time, things get settled down, and those medications, especially cyclosporine and tacrolimus, have a lot of different absorption from the individual. There is individual discrepancy in how they absorb it, how the liver metabolize it. So that's the main medication that we use, levels. Now, mycophenolic acid levels are helpful, especially if we're using we're using only tacrolimus and Cellcept, just to make sure they're absorbing it. They're not as essential. We tend to get the mycophenolic acid level when we want to test if the patient is taking their meds. Second, if they have GI toxicity, if they have severe diarrhea, if their levels are very high, 4 or 5, typically the range between 1.5 to 3.5. So we get the Cellcept level, and we adjust the level down, the dose down. Prednisone, obviously, there's no, but I would say the most important medication to follow levels on is tacrolimus or cyclosporin. Your second question about, that's unfortunate that when the patient get a kidney transplant, they lose their Medicare coverage after a while. This is a struggle because also Medicare only covers the immunosuppressive medication for 3 years. There is a lot of Congress people are advocating to have a bill of coverage, a lifelong coverage for immunosuppression. Not passed yet. We hear about it all the time. Because, Medicare save a lot of money compared to dialysis. They pay for the transplant once. The medication costs on average $1,500 a month. It's better than dialysis because they pay several thousand of dollars per month for dialysis patients. So this has been a struggle, Some patients, they come for their transplant evaluation. They meet with our social worker. They told them about the potential of losing their Medicare coverage, and they may not be happy about that, but that's a different topic. Yes?
Yes, years ago you could go to India and buy a kidney for $10,000, $20,000. Can you still do that?
No, that's unfortunate. It's actually illegal. It was the black market. India now banned it. It's not done anymore. There are some places that unfortunately still do it. Of course, it's against, it's illegal in the US to sell organs. It's illegal around the world as well. The only country that allow compensations for living donors is Iran. And they have very restrictive measures that they put in order to compensate the donor. They have to be Iranians. So no one can go from any country to get a kidney there. But it's illegal around the world. We used to see that, actually. Every now and then we see a patient coming from Pakistan or with a kidney and they want to make their follow-up here. I don't see it anymore. We used to see it a lot. Yeah. Question?
With recent approval of new logics, we've started receiving a few patients in our infusion center in the hospital, and I wondered what makes them a good candidate, and do you expect the use to increase?
Yeah, that's a very good question. Neurologics of belatacept is a new injectable medication. It's an infusion medication. It's a biologic that is used once a month, infusion, IV infusion. It has to be used, it was FDA approved 3-4 years ago to be used with Cellcept and prednisone. So we see more and more patients. We put some patients, typically patients who are not sensitized, patients who are worried about compliance with medication, younger patients we know, or people who are in institutions and where they cannot be provided with meds. We have few patients in prison that get actually Bella. At times also when some patients have marginal kidney function post-transplantation, they cannot tolerate tacrolimus or cyclosporin because of nephrotoxicity. We make a case of switching them to belatacept. So that's a new medication. That's actually a good medication. The only drawback of it, it increases the risk of rejection. The risk of rejection in the first year can be high. I said nowadays with Cellcept, Prograf, and prednisone, plus minus prednisone, the risk of rejection is about less than 10%. with belatacept can be higher, can be 20 and 30%. But mostly those rejections are treatable. They're early and we treat them. So you'll see more and more patients on that medication. There is a shortage now, probably you know, of it. So we're not putting any de novo patient. We have to get it approved. But yeah, it's one of the medications that we can use. Any other questions? This one. Thank you. Thank you so much for having us.